on Main 11 East. Have you taken care of a patient that's had Depadur or Duramorph for pain control post-operatively, like they would have gotten it in the OR? Does that ring a bell?
Oh wait, yeah. Is that the one where you have to have this slow Narcan drip afterwards?
Potentially, you might need to, yeah.
On the OR day.
Okay, but these patients normally don't have an indwelling epidural. Did this person not have that? It's just an injection, yeah. Yes?
They were giving Duramorph post-C-sections.
Were they? Okay, okay, all right. Because I had one student tell me last 8 weeks that she thought that one of these two products had been taken off the market, but I looked and I could not find that was the case, okay? So I just wanted to preface it by saying this. But a lot of times for joint replacement in certain settings, patients will receive Depadur or Duramorph. Now, Depadur, and don't ask me why, is only used for knee replacements, whereas the next one we're going to talk about, Duramorph, is used for knees and hips, okay? But they're both the same type of product. So Depadur is an extended release morphine. So it's that usually the patient gets it while they're still in the operating room, and it starts to work within 3 hours and lasts 48 hours, injected into the epidural space, and there is no indwelling catheter. Why do you think it would be a problem for somebody who's had knee replacement or hip replacement to have an epidural catheter through which pain medicine would be given in the first few days post-op?
They can't do therapy.
They're going to be on their back.
It would be on their backs. They could still do therapy, but with the immobility that is associated with joint replacement. Remember we talked about medication that the patient is going to be sent on to be on at home last week. I'm trying to get y'all. I'm giving you hints, but what if a patient is on Lovenox or particularly Coumadin? Why would it be a problem to have an epidural catheter? Bleeding in the epidural space. So that's why these patients often don't have epidurals. Now, I've had other students in 108 who've worked on orthopedic floors in different hospitals, and they've said, well, we take care of knee replacement patients who do have epidural catheters and get their medicine that way. But you can see how that would be an increased hemorrhage risk because you're on a blood thinner, okay? Lovenox less so than Coumadin, okay? And remember how we talked about a lot of times these patients with the joint replacements will be on Lovenox in the hospital. They'll start them on the Coumadin. They'll be on both concurrently in the hospital setting and go home on just the Coumadin because it takes a while for the Coumadin to get to the blood level that you need. So both of these products, Duramorph and Depadur, are given directly into the epidural space without an indwelling catheter. Yes?
Why is this medicine only used for knee replacement?
It can also, that's what I said I did not know the answer to. Okay? Duramorph is used for both knee and hip. Depadur only knee. I have never been able to find out. If you can find out that answer, will you tell me that? Okay. But they're both extended relief morphine products, okay? All right, so the potential side effects are the same for both of these medications. And these look rather familiar, I would think, because they're the same side effects that we see with opioid, you know what I'm saying, analgesics. Okay. Respiratory depression is your biggest worry with this medication, okay? Because this is in the system and, it's in there for a while, okay? And there's nothing you can do to get it out of that. But now your patient that was on a Narcan drip with this, were they respiratorily depressed?
No, the PACU nurse said that they would sometimes do that just in case because of the bad itching and stuff.
Okay.
Like the severe itching, that they just give it like automatically.
Okay.
But it's really slow.
A very slow one. Okay. So they're still getting pain relief.
Yeah.
Yeah. Okay. Okay. Now the hypotension that might develop, which is one of these things listed here, it could be the drug itself, but think about it. They've had blood loss during surgery. They've been NPO. They're on other concurrent medications that could be leading to hypotension. As far as urinary retention, I read less than 25% of patients that get Depo-Dur have problems with urinary retention. But still, I mean, that's a significant amount. Okay? Now, contraindications to getting Depo-Dur. Any contraindication to an epidural injection, if they have an infection in the spinal column, they're certainly not going to get something else injected in there. And this lists anticoagulation as a contraindication for an epidural line, okay? If they're allergic to morphine, I sure hope they're not going to be getting it in the OR. If they have history of respiratory depression, so any respiratory things that you think might potentially lead to respiratory depression, and then you add this long-acting morphine on top of it. So acute or severe asthma, upper airway obstruction. What about why paralytic ileus?
That's constipation.
Constipation, but this would be somebody that has a chronic problem with paralytic ileus, because they're going to have paralytic ileus right after surgery anyway, if they had general anesthesia. If they've had a history of a head injury or increased intracranial pressure, you're certainly not going to be injecting anything into the cerebral spinal area. Circulatory shock, and here's another respiratory issue, sleep apnea, obstructive sleep apnea. These people that have that, and these are often overweight people, obese people have sleep apnea often, they're going to be at increased risk for respiratory depression. So you would not add this medication on top of that to even increase their risk further. All right, antidote. We know it would be Narcan. So rule of thumb might be, and it depends on your institution, respiratory rate lower than 6 and with the SATs falling. You are not responsible for memorizing the dose of Narcan, because you can look that up, okay? All right, but this will certainly be on hand when somebody is receiving Depo-Dur. Now here comes Duramorph. Many similarities between these two medications. It's also a preservative-free morphine. It's used in hips and knees, and I'm sure other procedures as well. It may be given IM, IV, epidural, or intrathecal, which means within the spinal canal itself, not just in the epidural space. Again, no indwelling catheter. This one does not last as long as the Depo-Dur did. This one lasts up to 24 hours, whereas the Depo-Dur lasted up to 48. The contraindications are the same for both medications, and the potential side effects are the same. For some reason, Depo-Dur has less risk of hypotension than Duramorph. And of course, being a morphine, the antidote is the same, Narcan. Now, the big take-home message with this is frequent monitoring of your patient who has received either of these products, either of these meds. Respiratory rate, blood pressure, and heart rate. This would be institutionally specific, but in most cases, these patients have their vital signs monitored every hour for 24 hours, okay? Then every 4 hours for another 24 hours, and then after that they can drop to every 8. So it's the frequent vital sign monitoring that's the most important nursing intervention as far as this goes. And your biggest worry is going to be respiratory depression in this situation. And I'm sure these are used in other procedures as well, but since we're talking about it from a mobility standpoint, we're concentrating on the knee and the hip replacements. And a lot of this it's the preference of the anesthesiologist that's working with the orthopedic doctor. But I mean, these people have fabulous pain control. They get up and move around the night of surgery, just like some of your patients that you've seen on our general surgery floor that are, going to town the first night after the surgery because they've got an epidural catheter in place and they're getting all that wonderful pain medicine. Okay. So who might you think, and this just harkens back to, I guess it was post-op, the patients that tend to be candidates for indwelling epidural catheter pain management. You remember who those patients were? Obese patients, and why would that be?
Doesn't it have to do with their incisions?
Well, obese patients are going to be less likely to get up and move. It's going to be harder for them to get up and move around.
And the fact that they have
Abdominal incisions, thoracic incisions, painful incisions. Those people are going to be more likely to get epidural pain control as well. Those are the biggies. You know, people that you don't think are going to move well after surgery would be candidates if they didn't have any contraindications. Okay, so let's talk a little bit more about our ORIF of the femoral head prosthesis or pinning, the hip fractures. We've already talked about how we don't want the patient externally rotating that affected leg. And that's both pre-op and post-op, okay? We do not want the patient forcing the hip into greater than 90 degrees of flexion. Can you give me an example of an activity that flexes the hip into greater than 90 degrees of flexion? I'm sorry, what? Actually, okay. To sit in a chair is 90 degrees, right? But what about the reason why these patients get elevated toilet seats at home? So they don't have to go more than 90 to get up. So this is okay. This is not. That's more than 90. Okay, so bending over to put on socks and shoes. That's a no-no, okay? I always talk about how, occupational therapy will give these patients, the grabbers. And my daughter had the toy, the grabber. Children have the grabber toy. And I always thought about it because when we would ride around in the car when she was little and was in a car seat and she dropped something on the floor and I couldn't reach back in, she'd get the grabber out and pull it up. So she was using some occupational therapy devices in the car. They come in handy. Okay, patients are not to cross their legs, okay, because that's going to potentially get them out of alignment too. So as this says, we don't want them externally or internally rotating, okay? We do not want them forcing their hip into adduction. You remember from 226, what's adduction? That's the crossing of the legs. That's bringing it, more than midline across the body, okay? Okay. So, use elevated toilet seat, use shower chair to stay seated during shower. You can use regular pillows or you can use an abductor pillow, which I'll show you a picture of. Keep hip in neutral, straight position when sitting, walking, or lying. And these people are, back to our pre-op antibiotic business, they're always going to get antibiotics before they get their teeth cleaned or have dental work because they fall into the same category as anybody that has any foreign body in the body. We don't want that getting infected. So they're on lifetime dental prophylaxis, before they get their teeth cleaned. Okay. Here is an abductor pillow. Doesn't look very comfortable, but it keeps the legs in abduction so they don't adduct. So you can imagine when a patient's turning in bed, the substance it's made out of gets hot and everything. So sometimes you'll see just one or two pillows used instead. But if you were turning a patient on their side and they did not have an abductor, that leg's going to adduct and potentially dislocate. So you'll see these used. So post-op hip fractures, we have our usual post-op nursing care listed here, and signs and symptoms of hip dislocation are going to be shortening of the affected leg. So, and sometimes they'll even get a bulge in their buttocks when the hip dislocates. The leg is shortened and they're going to have external rotation. So those would be signs to look for dislocation. Okay, so severe pain, lump in the buttock, limb shortening, and external rotation. And here's the overwhelming one, and if you get into it, take a look at it, because it just has all the stuff we've been talking about, just in that kind of format. Okay. All right, so knee replacements. We're seeing more and more knee replacements. So y'all have seen a few on Main 11 East. Have they used the continuous passive motion machines?
My mom has had double knee replacement. And
She used those, yeah.
They sent them home with her.
And I'm sure Miss Hatcher wouldn't mind me saying she had shoulder surgery guess it was last fall. Did she talk about, and she used the CPM on her shoulder. And she had the big fancy ice thing going too at home. Yeah. Okay. So early initiation of range of motion of the joint is very, very important, as it is with the hips. I mean, these people are going to be getting up, walking, etc. Well, in the knee replacement, oftentimes they'll be put on the CPM machine in the PACU, and they'll come up to the floor with it on, okay? And the goal of that is to eventually get them up to a 90-degree range of motion. Yeah.
A question.
Yeah.
And maybe you can't answer for me. What is the determination whether or not they'll do a patellar repair versus a total knee replacement?
Well, if it's only the patella that's fractured, they don't need the whole joint replaced necessarily. Usually, knee replacements are for interarticular fractures, where the actual joint has been fractured.
Okay, so
Yeah.
the kneecap itself is just
Yeah.
a smash.
Yeah. And osteoarthritis is a huge cause for knee replacement surgery too. Yeah. Used to be knee replacements were really, really, they lost a lot of blood in knee replacements. There's still bloody surgeries, but they seem to have contained that less. And nowadays they're, pretty common. Let's see. So if you use the CPM machine, it's going to increase your chances that you're going to get real good range of motion on that knee joint, and it's going to cut down the prevalence of real post-traumatic arthritis. Although I would say most people who have knee replacements are going to have some degree of arthritis as time goes on, but it's still going to be less than they had before they had the knee replaced.
What does CPM stand for again?
Continuous passive motion.
And then you graduate through the motions, obviously, but then when my mom had it done, there was actually like an angle of inversion of the knee that you have to progress to, which she clawed the ceiling. Like it was sure
Painful.
Yeah, so they keep you straight, and then they gradually do the increase, but then at some point they start to let it
Do
go
it down
down
the
a little
other-
bit to make sure that it's still stable that direction. Yeah.
Did she do a lot of physical therapy too?
Yes, yeah, she did a lot of, they had a PT come to her house, and they kind of on like a loan rental basis had the CPM there, and then after she finished PT, the PT took the CPM back.
I have a friend who has had both of her knees replaced, and she talked about this excruciating. She waited a real long time to have the second one done, and had no range of motion or anything in the knee, and they actually, in physical therapy, a lot of times almost like break up adhesions that are forming. And she said that they would, like, two physical therapists, one would grab her above the knee, and they push down just as hard as they could. Yeah, it's kind of rough. Yeah. And if it's been a long time coming and you've waited a long time, it takes a long time to get that mobility back. Okay, so a lot of what we talked about as far as post-op and everything with knee is going to apply to what we talked about with hip, okay? But of course not the signs and symptoms of dislocation of the hip. All right, then we're going to just talk a bit about pelvic fractures. And we already talked about what is what we started off talking about today, the fatty embolus syndrome. That's often that's seen in a big fracture like a pelvic fracture a lot of times. Okay, if you follow these two columns down, they're pretty much exactly the same between an open book and a closed book fracture. The difference between a pelvic fracture that's known as an open book fracture is an anterior to posterior fracture. So the person's been hit either from the front or from the back, and the fracture has occurred that way. So external force pulls pelvis apart, struck or crushed from the front or the back, whereas with the pelvic closed book fracture, that's a lateral hit. And a lot of that just depends on where the fracture occurs in the pelvic rim, okay? But as you can see, fatty embolus syndrome, sepsis, DVT are both high mortality risk with pelvic fractures. And everything else as you go down the lines is the same. Okay. Now, if a pelvic fracture is displaced, they're going to try to get that back in alignment and get people up walking as soon as possible, because the immobility is the issue. So, what we need to keep in mind is where the pelvic bones are located. What else is in that area? A lot of stuff.
Organs,
Yeah, a lot of very vascular organs, close to major organs and blood vessels. So when you have somebody with a pelvic crush injury, you've got to worry about what else happened just besides the bone breaking in there, okay? So we're going to be monitoring for blood and urine in the stool even. I mean, they could have ruptured a bladder, they could have ruptured a colon, they could have developed peritonitis, and when they develop peritonitis, what are we looking for again?
Rigidity, guarding.
Guarding, what else?
Cord-like rigidity,
Rigid.
abdominal distension.
Abdominal distension can occur. Elevated fever, if it is going on long enough. Tachycardia, yeah. Okay, so we got to think about where that is. Okay, so if it's a non-weight bearing fracture, in other words, like the iliac crest is broken, or the pubic rami, that thinner part, it's a non-weight bearing area, it's very painful for the patient, but no treatment is really, surgery might not be needed in that case. There are a lot of pelvic fractures that the patient does not undergo surgery for. But unfortunately, they spend a lot of time in the bed waiting for them to heal. If it's a weight-bearing part of the pelvis that's been fractured, they're going to have an external fixator placed, or they're going to go in and do an ORIF so that they can facilitate weight-bearing sooner. What we want to keep in mind with pelvic fractures is the fact what it's close to and some of the associated signs and symptoms you're going to be looking for, and also the risk factors associated with it. When a lateral, you think of crush injuries usually are going to be anterior or posterior, and the lateral fractures are going to be from falls. That's usually the way that happens. Now, we don't spend a lot of time talking about the lesser bones, although these can cause a lot of problems too, like a Colles fracture is a fracture of the distal radius, which often occurs in osteoporotic people. When they fall, they stick their hands out, to stop the fall, and they end up breaking their distal radius. So very, very common in osteoporotic women. After this is repaired, people can later develop carpal tunnel syndrome from the surgery. But this is a very, very common fracture in older women. Okay, but it's not associated with, it wouldn't be common to see fatty embolus syndrome. It would be common to see compartment syndrome if the cast is too tight, if they wear a cast. But you're not going to have the DVT worries with the upper extremity as you do with the lower extremity or pelvic fracture. Okay? Same with the fracture of the humerus. So you're checking for radial nerve injury and vascular injury. Neurovascular checks are important for every kind of fracture. Okay. We want to touch upon herniated intervertebral discs. Causes of herniated, has anybody in here had a herniated disc? You have, Scott? Okay. Did yours resolve with medical management, or did you have to have surgery?
No, I had chiropractic.
Okay. And did you use a lot of non-steroidals also? Yeah. Okay. The causes of intervertebral disc herniation is usually age-related, which in Scott's case that wouldn't be the case because he's not that old, or repeated stress to the area. Okay. And the most common site of a herniated disc is in the lumbar area. Was yours in the lumbar area, Scott? Yeah. Okay. All right. So you've got the symptoms listed here, okay? And of course, a lot of the symptoms, it depends on what level the disc is. I mean, if you herniate a cervical disc, you're going to have arm pain. It depends on the level at where it's herniated. But usually the patients have paresthesias, Numbness and tingling. Did you have numbness and tingling of the feet and
Yeah,
legs?
it radiated down like through my sciatic. and
Yes.
things like that.
Okay, which is what's listed right up here too. Did they do the straight leg raise on you when you went to see the doctor the first time to see if that elicited the pain? Okay. And you can also have decreased reflexes too. They'll check your reflexes and see how they respond. So, degenerative disc disease is very common in a normal process of aging, because when we talk about cataracts, we'll talk about what happens with the lens of the same thing happens to our disc. They lose elasticity and flexibility and moisture even, and they don't have the ability to work as a shock absorber as well. And patients, the people that have spinal stenosis or real narrowed spinal canals, they're going to be more likely to have problems with disc herniation as well. So with herniated discs, diagnostic tests. What did you have done, Scott?
X-rays.
You had x-rays. Okay. A lot of times they'll do a myelogram. Does anybody know what a myelogram is?
Inject dye.
That involves dye injection with a series of x-rays. An MRI is really a good test to show a disc herniation. An EMG stands for electromyogram, where they're checking out your muscle activity with electrical stimulation. Okay, so the early management is usually going to be medical. I mean, most people that have a herniated disc don't rush right into surgery, okay? So the rule of thumb is usually at least 4 weeks of conservative treatment, which can involve any of these things listed here, okay? A lot of times heat ultrasound, I don't know if they did that on you, that really supposedly feels good.
Yeah, it works great. The
Yeah.
TENS unit works really well.
And the
too.
TENS unit did too, yeah. So, a lot of times what it takes is just some time and anti-inflammatories to make that inflammation decrease to the level where the disc gets off the nerve root, and then your pain goes away.
And they give you real high doses of vitamin D.
Vitamin D. Did they give you steroids at all? Sometimes they'll do that.
They can, but I
Didn't want to take that. Okay.
What does the NA stand for? NSAIDs, NA, muscle relaxants?
That's narcotics.
Narcotics.
Yeah. NA would be narcotics there. I mean, this can be extremely painful situation, extremely. So, surgical options. If the medical conservative treatment doesn't work, usually the surgery is performed through minimally invasive procedures, okay? Now, they may have to go in and open it up, though, if the disc is compressing the spinal cord, because they need more room, to see what they're doing. It's a more tricky procedure. But with minimally invasive surgery, you're going to have all of these advantages here, which I know we've been over this many, many times with many, many procedures for minimally invasive. And then the conventional open procedures, when you hear the term discectomy, that just means the removal of the herniated disc. But in order to get in to do that, they have to do a laminectomy, when they remove part of the lamina, of your spinal column and get right into the disc space. So I don't think you can have a discectomy unless you have a laminectomy also. And if you have, usually if you have 2 consecutive discs that need to be removed, they do very much recommend that you have spinal fusion. And in order to do that, they will take a lot of times they'll take iliac crests, posterior or anterior iliac crests, break up the bone fragments and put them in that area. And then the bone grows and it gives you stability in the spinal cord. Or they can use donor bone to do that. Now, when you have spinal fusion, it's going to increase your chances for arthritis development. And a lot of times they'll try to fuse even one disc removing, but it's a necessity if it's more than one. And they've been in there and done laminectomy on 2 separate joint spaces, because there could be some instability. Okay, but it is possible to have one disc removed and not be fused. Okay, so from a nursing standpoint, in the post-op care, if the patient stays in the hospital, it's spinal alignment. We don't want any of this action, like with any of this twisting action post-operatively, okay? So when they're turned in the bed, they need to be log rolled. Log rolling is at least a two-person situation. It's impossible to log roll a patient by yourself if you're doing it the right way. Yeah.
Especially with a huge patient.
Yeah, especially with the big patient. Okay. We're monitoring for the dressing not only for bleeding but for CSF leakage, like we talked about with epidural cast. Frequent neurovascular checks. Monitoring for adequate bladder emptying. And what is the best way to get a patient to be able to void? It's not. They stand them up at the side of the bed, right? A lot of these patients will have braces ordered, a brace for stability, and they will often, a lot of times you will roll them side to side to get them in the disc, log roll them and get them in the brace, and then it's a slow process getting up because they cannot twist as they get up to stand by the bed, okay? All right, but the voiding is very important to assess, particularly if the surgery's been in the lumbar area, in the sacral area. You want to make sure that there's been no nerve root disruption that's affecting voiding. So as this says, oftentimes a rigid brace is used postoperatively, and a lot of times the patients complain more of the bone graft donor site than they do of the actual spinal incision. Okay. They may be on bed rest for 24 hours following the fusion. That's up to the surgeon to order. A lot of them get up that night. How are we doing? We're almost done. Okay? We've only got to talk about, what do we have left? Not too much more. We're going to talk a little bit about amputations.
What is the
Okay?
NI again? I'm sorry. All these.
Nursing intervention, is that what? Yeah, sorry. Okay, amputations. This is so weird. Your book refers to amputations as being elective if they're a result of peripheral vascular disease or arterial sclerosis. I think of elective surgery as something that you almost don't really need, but they use that term, whereas the other category is traumatic. And traumatic amputations are usually of the upper extremities.
So just for our own purposes, if they have peripheral vascular disease and then necrotic tissue, we're considering that elective?
Well, I'm not using that term. I brought that up because that's what the book uses. I don't really. If they have necrotic tissue, that's setting them up, for septic shock or whatever, and I don't consider that elective. So I don't understand that terminology.
They're probably thinking like my patient that I had
Was putting it off and putting it.
She didn't want it, and they didn't consider it emergency enough to take
Right,
it, so.
right.
So I guess in
That
that,
may be what
I
they're
guess in
thinking
that
of.
situation, they could just sign against medical advice.
Or have it.
Or
Yours.
keep having it debrided like she was doing. That's what but she doesn't even have a foot left. It's
Yeah.
just,
If you debride long enough, you end up with
right,
an
and she's like almost there, not having anything there.
Debridement is just a basic whittling away.
Exactly.
Anyway, so
Exactly.
she's just electing for a slower,
Yeah.
progressive.
Exactly, she's just she keeps going back in.
Probably a psychological.
Oh, well,
thing,
I mean,
too.
you're
You
trying
have
to
to
hold on
get
to
a
the-
saying go ahead and
woman
take my
stuff.
foot,
Exactly.
that's still such a difficult thing. to
Exactly.
ever think about.
Definitely. Definitely. So levels of amputation, there's an LE, another abbreviation. This makes common sense. The higher the level of amputation, the more energy is going to be required for that patient to ambulate. We're talking about lower extremities postoperatively. So if you have a toe removed, of course a great toe removal can affect balance and ambulation to some degree, but that's going to affect you a whole lot less than if you have an amputation all the way up to the pelvic area. So that's just common sense. That makes sense. Okay, complications. Oh wait, I skipped one. Complications of amputation listed right here. Let's talk a little bit about hemorrhage. Okay, we're going to be monitoring post-amputation. We're going to be monitoring the skin flap for the color. Okay, and your book talks about how it should be warm to touch. And a rule of thumb is that the color of the skin flap should not be lighter than the person's normal skin color. So in other words, if you have a patient, an African American patient, the flap on that amputation should not be lighter than the rest of their skin tone, okay? Then again, it shouldn't be darker either, okay? And in a Caucasian patient, we're looking for something that's pink, pinkish. We don't want it, beefy red. We don't want it to have pallor, okay? So it'd be a lot whiter than what you see in the normal. Which pulse are we really, really interested in?
What?
Which pulse? Well, depending on where the amputation
Depending on where the amputation is, yeah.
We're looking for the most proximal pulse to the amputation site, okay? So if they had their great toe amputated, you're looking at their dorsalis pedis and posterior tibial. If they had a below-the-knee amputation, you're checking the popliteal, okay? So the most proximal pulse.
Everything has all the way up to the pelvis.
If they have it all the way up to the pelvis, well, if you can't get you should be able to get femoral. And femoral is a glove situation. That's the only pulse that's a glove situation, okay? Otherwise, I understand, or unless you have open skin and something oozing. But I don't like gloves on pedal pulse checks. That gets me, because I can't feel it well. But femoral, yes, I'll go there. Although if y'all remember, if you all watch those old videos in 226, I don't know if y'all saw the old-fashioned ones or not, you probably came along. But they had these old-fashioned, they weren't even on discs, they weren't 8 tracks, but they were the fatter tapes. They never put gloves on, when they checked the femoral pulses or anything. It was creeping me out. That was weird. And the patient wants you to wear a glove too, I think.
What do you think?
All right. So let's talk a little bit about phantom limb pain. Here's another abbreviation, PLP. Okay. Now this is where it comes in. It's very important, as we talked about post-operatively, to assess fully the patient's pain, to get a good idea of what type of pain they're talking about, not to just assume it's incisional pain, okay? So it's important to distinguish phantom limb pain from residual, which is residual limb pain, from incisional pain, because they're treated in different ways. People that are going to have phantom limb pain are usually people who have had chronic pain in that area before the surgery. So something that's been going on for quite some time, we're going to be more prone to develop that. And your book talks about how in some cases phantom limb pain is not treated with narcotics like you would with incisional pain. It's often treated with IV infusions of calcitonin. Calcitonin, and it's either your book or another textbook said that that's usually done for about the first week post-op. Whereas if it's the incisional pain that's bothering them, they're going to be getting an opioid.
What does that do to stop the pain?
Don't ask me how it works chemically, but it's been proven to be more effective for phantom limb pain than narcotics. And some people will complain of phantom limb pain for years after surgery, but usually it's more short-term in nature.
I'm going to add that to my extra credit list.
Yep.
So.
There you go, Clay. You can present that following the final exam. Get up.
Following the fun.
Yeah. Okay. All right. A neuroma. A neuroma, but that's not going to give you a 79.5. Okay.
So close.
All right. Okay. A neuroma is a tumor consisting of damaged nerve cells. It's not a cancerous tumor. A neuroma, right up here, it's a tumor consisting of damaged nerve cells. It's not a malignant tumor. I mean, it's not a cancerous tumor.
That happens after the
That
amputation.
can happen after the surgery. More common in upper extremities. It can happen pre-surgery or post-surgery, actually. And then following amputation, flexion contractures are very common. They can occur after amputation, mainly of the lower extremities. So, yes?
How do they decide, like you were talking about the skin flap, how do they decide
Well, sometimes with like a below the knee amputation or above the knee amputation, they use they'll use the leftover skin. They'll take the bone.
Right.
If the skin is healthy, they'll just bring it up like that. But a lot of times they use thigh skin. Yeah.
I was just wondering, because I met someone who had their foot amputated from an accident, but it just cut in the middle of his foot off.
Okay.
And they actually, instead of bothering to take thigh skin or anything like that, they took skin from his back. But his back had a big back tattoo, so he's missing half of his tattoo on his back, and it's now on his foot.
Wow.
So I was just wondering why they would pick that skin over,
I have no idea.
if that makes.
I don't know. I don't know if what from the injury, was his thigh skin injured in that?
Not that I know of. It was.
I would think back would be. That would be really uncomfortable.
Yeah. That's why I was just curious what qualifications.
And of course, it's interesting. Has anybody here been able to see a procedure where they do a skin graft and what they do with the skin?
Seen it after.
Yeah, they run it through a
Like a pasta.
yeah, like a pasta, to put holes in it, and then that way it can cover a greater area. And, you'll see the skin, and it looks like a waffle almost, and the skin fills in, but that's the way they'll take a smaller piece of skin to cover a larger area. It's almost like a cheese grater.
What did you say about flexion contractions?
Okay.
occur most often?
Yes, flexion contractions occur most often in lower extremity amputations. So the name of the game in preventing this is range of motion exercises early, okay? They talk in the book about how it's important to have a firm mattress and not a soft mattress with a lot of give. Because think about if you are lying on a soft mattress, you're going to be able, to contract easier. Kind of, double over. Prone position. If the patient's put in a prone position for 20 or 30 minutes every 3 hours, that means face down. That's great, to prevent, instead of always being in this position, they flip them over. And kind of like your mom's knee in the machine, that is a technique that's used to prevent contractures.
How often?
Your book says every 3 to 4 hours for 20 to 30 minutes. And elevation is very controversial with amputations because it could actually promote contraction fractures. You can see how elevating it up, but I think a lot of times you still see the elevation. Okay, people who've had lower extremity amputations, it's great to have a trapeze on their bed too because it makes them a lot more mobile and getting around and helps with proper positioning. And your book talks about the proper way to wrap an ACE wrap, so it's going to be more constrictive distally. So it's tighter distally and loosens up a little bit as you move proximal. So nursing diagnoses for amputations. What can y'all give me?
Self-image, disturbed self-image.
Yes, disturbed
body image,
self-image
whatever.
or body image.
Decreased mobility.
Yes, decreased mobility,
Infection, risk for infection.
risk for infection.
What would be the one where they can't do the activities that they were doing? I
Uh-huh.
don't know how to say it.
Limitations of something like that, ADLs.
Ineffective tissue perfusion.
Ineffective tissue perfusion, chronic pain or potential or risk for chronic pain related to the phantom limb pain. That would be more chronic in nature.
The self-deficit stuff.
Yes. Okay, good. So, let's see what we got coming up here next. Arthroscopy. Okay. So arthroscopy, very common surgical procedure. It can be either diagnostic or surgical or both. Like they can go in and look around in the joint, see something wrong and fix it, okay? It's usually always done ambulatory or same day, and the knee and shoulder are the most common joints where this is performed. Okay, contraindications. If you have an infected joint, they're probably not going to go in there and muck around with it. They're going to treat you with antibiotics first and get the infection under control. And with knee arthroscopy, they have to have at least some degree of flexion to be able to get into the joint space and do the scope. So, this might potentially be an area where they might use Buck's traction to increase the joint space so that then the surgeon can go in and actually get in there and see what they need to do. So post-operatively from arthroscopy, we've got neurovascular checks, ice and elevation. They're going to be sent home to follow up in about a week, okay? And increased swelling, joint pain, and signs and symptoms of infection or DVT, they need to notify the doctor sooner. Preoperatively, they're usually instructed about straight leg raises, you know, how to perform straight leg raises, and quadricep setting exercises, like, you know, where they tense their quadricep muscle back and forth for exercise. Not always are these procedures performed right after surgery. That depends on the orthopedic surgeon as to how quickly he wants the patient to start doing that post-operatively, but they usually don't wait real long because they don't want them to get stiffer. They want to be active in the range of motion. So these are usually done outpatient. Okay, so we got through all of that. That's our mobility. That's our mobility unit. And as I said before, perception and sensation is very small unit. I think we only deal with either 2 or 3 ocular surgeries. All right, so let's take a little break, and then what we're going to do is I've got 3 case studies. 2 of them are GI, and 1 of them is GU. So I would like us to divide into 3 groups. I'm going to give you copies of all 3 of the case studies. But let's see, how many people do we have? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 1, 2, 3, 24.
Yeah.
So
Have both answers in the calendar.
let's get 1 group of, you were begging us next to 3 groups of 8. Let's get 3 groups of 8. Take a little 10-minute break. 3 groups of 8. This group of 8 up here, y'all can do GI 1. This group can do GI 2, and y'all can do GU. And then we're going to take a few minutes to run through them, and then we're going to talk about them real quick.
Okay, I have to think on that.
Sound both.